Go.
All right, good morning and welcome to the Department of Urology's Grand Rounds. By way of introduction, I'm Raj Pruthi, the new chair of the Department of Urology. I started in January and it certainly has been quite the onboarding. But I am glad to be here at UCSF working through this crisis with some of the most intelligent, thoughtful, collaborative, and compassionate people I have ever met. This morning we have a UCSF legend, Dr. Paul Volberding, joining us to talk about his experiences and observations with 2 epidemics here at UCSF. If you have questions for Dr. Volberding, please enter them using the Q&A function and we'll have some time at the end. I also wanted to thank Dr. Marshall Stoller for putting together this timely Grand Rounds on our behalf. I'll turn it over to Dr. Peter Carroll to formally introduce Dr. Volberding. Dr. Carroll?
Raj, thank you very much. Again, my name is Peter Carroll and I have the honor of introducing our speaker. Paul Volberding completed medical school at the University of Minnesota, residency at Utah, and a fellowship in medical oncology at UCSF. Paul, I hope I have this right, but I read that after your fellowship, you were immediately recruited to start a medical oncology service at San Francisco General.
That's right.
And it said that on the first day of your faculty rounds, you saw a patient with Kaposi's sarcoma. And this was the start of a remarkable career, which continues to this day as one of the most familiar faces in the ultimately successful campaign to manage the AIDS epidemic at General and around the world. Although he led and participated in many clinical trials, he had an early focus on the development of antiretroviral therapy. He was PI and co-director with Warner Green of the UCSF Gladstone Center for AIDS Research, supporting a large community of HIV investigators in San Francisco. He was chief of the medical service at San Francisco VA Medical Center and stepped down in 2012 to become the director of the UCSF AIDS Research Institute. He serves as the director of the Institute for HIV Cure, working with leading scientists at UCSF and the Gladstone. He's a member of the National Academy of Sciences and the National Academy of Medicine. His activities are boundless, boards, editorials, editorships, and they're too numerous to include in a brief introduction. He and his wife, Molly Cook, also a distinguished educator, clinician scientist, are household names at UCSF and around the world. Now, why am I introducing Paul? I came to UCSF in 1979, in July of 79, and I witnessed the epidemic and Paul and Molly's remarkable work early on and over the years. I've held many positions at UCSF over the years, and I'm currently co-faculty lead for the UCSF campaign. And I happened to hear last year one of Paul's numerous interviews on NPR, and he gave a remarkable one in July of 2019. So as my role in the campaign, I'm often called on to describe UCSF, what it is, what it does, and how it is different. And I was asked this in front of a group in the fall of last year, and now, rather than cite rankings and numbers, I simply tell people if they really want to understand the richness of UCSF, simply look at its response to the AIDS epidemic in the 1980s. I think this is a remarkable testament to how UCSF does things and how it responds to crises. So hence I asked Paul to deliver our grand rounds. Now, what I could not have anticipated last year was that we would have been in another epidemic, a pandemic. And it's remarkable that we're facing this epidemic, and I'll ask Paul to speak to both. Paul, thank you very much for accepting this invitation.
Thanks. Thanks a lot, Peter. And I'll try to share my slides here with the screen. Can everyone see that, Raj?
Yes.
Yeah. Okay, Peter, thanks so much. You know, when I was invited to give a urology grand rounds, it was a number of months ago, and I expected, you know, I'll talk about AIDS, but I thought probably I'll mention something about prostate cancer and HIV. I have a couple of patients. Actually, if anything, the incidence of prostate cancer is lower in HIV than not. So there's not that much to say to urologists about HIV. But you know, as Peter said, the last few months. And as Raj said, since his arrival, what a bad time to arrive. We've been just focused on nothing but this. We're now sitting in our houses for the most part. But I'd like to talk about this. You know, it's a time when I do want to talk about some of the lessons that we may have learned from AIDS and how that might apply to the current pandemic. I'll say when I do that it's probably actually too early to make those guesses. I think some of them are going to be obvious, but we don't know where this epidemic is going yet. So I think, and we're all just riding this wave. But we did have experience with the AIDS epidemic, and as always, UCSF and San Francisco General respond to whatever challenges we face. We do it by jumping in clinically, but also by being what we are, which is academics, and realizing that the only hope we have of these things is to understand the challenge that we face, and that was certainly true with AIDS. So here is, let's start, and by way of starting, before we start actually, a couple terms, I hope everyone knows this, but HIV is the retrovirus that causes the clinical disease we called AIDS. Before we had the virus identified, all we had was clinical definition, and so HIV is the virus that causes AIDS. In this current pandemic, SARS-CoV-2 is the coronavirus that causes the clinical disease we call COVID-19. A lot of us kind of switch these terms around back and forth pretty fluidly. I think that's fine, but I'll try to refer to the name of the virus when we talk about the virus, and the COVID-19 when we talk about the disease. So really quickly, I'll talk about some of the early experience that we had with the HIV epidemic, and with the San Francisco and definitely a UCSF perspective as well. I'm an observer of the current epidemic. I'll talk about what some of the things we're seeing now, and at the end, I'll really try to propose some interim lessons that we might have from our experience. There are a lot of places to start for people that weren't around in the early 80s. I would start with Randy Schultz. Randy was one of the first journalists, first gay journalists that reported on the AIDS epidemic, and wrote a book that became a movie. But the book is really very good, and it has a strong San Francisco focus. So many of the people that I'll mention are in the book, and he does a really nice journalistic job. The only thing he got wrong was that he referred to one of the early patients as patient 0 when it wasn't the first patient in the country. But otherwise, it's a really good book, and I'd encourage you to read it. Now, I started at San Francisco General Hospital on July 1st, 1981, and before I started as an oncology division chief, I did that, as Peter said, right out of my fellowship. I did my fellowship in oncology and studied viruses. Actually, it was in a retrovirus lab of Jay Levy's. And went right from that to become a division chief on my first day on the job, and that was July 1st, 1981. A paper was published in the MMWR, the CDC publication, just on June 5th, from Mike Gottlieb and others in Los Angeles, on a very small cluster, 5 young men with an unusual I didn't pay any attention to it. I don't think I really noticed it. But when I came on rounds that first day, I saw a patient, not this patient, but I saw a patient with this cancer. This is Kaposi's sarcoma. I was rounding with my first day fellow. Fellows start on July 1st. So Ray Stricker and I were rounding together. We saw a patient with KS. And he was a remarkable sight. He had KS everywhere, and he was gaunt and just looked terrorized. And Ray said, you know, I think we saw some of these in New York. He had done his residency at St. Luke's Roosevelt, and he called back and said, yes, there are some patients with this in New York City. And this was the beginning of the epidemic. We had patients here that in retrospect had AIDS, but this was the very first patient that I saw on my first day on the job. So we asked a lot of questions. You know, this was a mystery. I've been asked whether I was immediately afraid, and no, I really thought of it as an interesting, exciting kind of thing to see something so new. When I looked in the books, the capaces wasn't supposed to be in 22-year-olds, supposed to be only in old men, and I had just studied for my oncology boards. Didn't manage to study KS because I knew it wouldn't be a question on the boards. So it was a really unusual thing. How did it happen? How did this new epidemic spread? And there are some parallels between what we saw in the AIDS epidemic and what we're seeing today. Like the coronavirus, this is a zoonotic infection. HIV, and a really wonderful scientist, Beatrice Hahn, who's now at Penn, has done a lot of incredible field work where she's identified that there were several separate jumps of the virus. HIV is a chimpanzee virus from chimps to humans. Actually, we don't know precisely. There may have been jumps even earlier, but a number of decades before we saw our first patients at any rate. Started out in West Africa. We think that it was a very small scale, endemic, kind of no one really noticed it disease. But as urbanization happened, post-colonial Africa, transportation improved, this spread to East Africa. And we think that the first really concentrated epidemic was probably in or around Uganda. And then the question is, how does a virus like this spread? And I like this really ancient newspaper graphic. The numbers that you see on it are not really correct anymore. We have a lot more information about how the virus spread. But just as we've seen with first SARS and now with SARS-CoV-2, epidemics use the most rapid means of transportation they can get access to. You know, cholera may have been on horseback and sailing ships, but the recent epidemics that we've seen sort of, in a sense, recognize that there are jets flying all over the world, and a disease that starts even in East Africa can very soon find its way to every part of the world. And this epidemic, the AIDS epidemic, spread a little bit more slowly. It started in a place without an extensive commercialization that we saw with the outbreak in China recently. And we've done some incredible things. Not me, Michael Warraby, especially in New Mexico, has looked at the genetics of the virus and can really identify when the virus goes from one place to the next. And we now know that HIV found its way probably from the Caribbean to New York in about 1972 and landed in San Francisco in about 1976. So we were here. I came in 1978, and really by the time I saw my first patient in 1981, the virus had already spread widely in San Francisco, well before we could have known anything was happening. Another old slide, really ancient slide from the AIDS epidemic that is kind of interesting to go back and look at today, shows that not only did the virus spread rapidly in cities like San Francisco, but it spread across the country. And if you kind of look at this and kind of think about the coronavirus epidemic, while here you're looking at kind of years and over the first decade of the epidemic, what we've seen with the current epidemic, the current pandemic, is the same sort of spread, but in a super accelerated way. If you look at the top left panel in February of 1983, there were a total of about 1,000 cases. The bottom right, I said the top left, the bottom right, by August of 93, there were about 330,000 cases. So there was a rapid spread, but it took a decade to do that. And it affected mostly large urban areas, given the nature of this disease. Now, we've seen other recent bad diseases. We've seen Ebola. We've seen others. But when we think of what defines a bad disease, one, it could be the rate of transmission or the fraction of the population at risk. But another would be just what the likelihood is that a single infection will kill you. HIV is still unique in some important ways. It's a disease that's not spread through the air. It's not spread by fomites on surfaces. It's spread by sex and blood. So people don't have a uniform risk for HIV, as we all know. It's a sexually transmitted disease primarily. And so unlike what we see with the current situation that we're all going through, in fact, a lot of people didn't really have any particular risk for being infected with HIV. But HIV infects people. It makes people, in many cases, sick briefly, but with a self-limited symptomatic phase, it goes into a silent phase that can last really literally years and maybe even more than a decade, during which time the virus is being replicated, during which it can be transmitted, and at the end of which, by the time people became symptomatic, this virus kills essentially everybody. Without treatment, there may be a couple % of people with HIV infection that remain ostensibly healthy, but when we saw our patients in the early epidemic here, every person that came to see us because they had noticed some symptoms or signs, every person died. This is and it quickly became the leading cause of death, as this panel shows for young men. So HIV has some properties that make it really worth thinking about, and we'll talk about that when I talk about some of the lessons at the end. Now, what did we do in San Francisco? We developed what was called, I don't think anyone gets credit for naming it, but the San Francisco model. We were looked at around the world as really a pretty remarkable place that responded in a what looked coordinated fashion that really addressed many of the challenges. So the community and response, and I'll break that down into the medical community, the affected population, and some of the political aspects of it. But there are many things to say about the response in San Francisco. And I think one of them should be that the role of UCSF combined with San Francisco General Hospital and the health department are really important players. I'll touch a little bit on them. The medical response. This was, when I came, this was called the new San Francisco General Hospital. This is the hospital building that opened, I think, in 1977. But this was a hospital that really responded in a truly remarkable way. The past to tuberculosis, yellow fever, and other challenges that San Francisco faced. SFGH really was the site of a lot of important developments. I don't think it would have happened without the relationship of UCSF either, because our response was very academic along with patient-oriented, but the role of the hospital was important. Now, do this advisedly, but my wife, Molly Cook, as Peter said, was here in those early days as well. She tells an interesting story that when she was a chief resident at the General, with Chip Chambers, who later had a distinguished infectious disease career, they would hear interesting cases in Morning Report, as is always the case. And she recalls during that year that they would hear of unusual cases of unusual infections in homosexual men, and it was always young gay men. And they didn't quite put it together as the beginning of a new epidemic, but in retrospect, a lot of us can remember patients even before AIDS was kind of announced, that in fact must have had AIDS. I had a patient with a very aggressive non-Hodgkin's lymphoma during my fellowship that I think must have had AIDS-related non-Hodgkin's lymphoma. But the role of the residents, the role of the academic medical enterprise is a really important one. And the person leading the report in the morning was this man, Merle Sandy. Merle came in 1980 as the medicine service chief at San Francisco General Hospital. He was an ID trained person, came from Virginia, but had actually trained at Cornell. And interestingly enough, given what's happened in our country, Tony Fauci was one of his interns. Merle was amazingly kind of onto the AIDS issue right from the start. He was supportive of everything that we did. His instincts were really very strongly positive, and lots of credit. He unfortunately died of myeloma in 1996. Actually, that's not true. He died a little bit later than that, but he was the chief until 1996. So what happened at UCSF? I want to spend just a minute on this slide because in looking back through some of the documents that I've been playing with, I was reminded of a really remarkable thing. When I saw my first Kaposi's patient, I ran into a dermatologist at Parnassus one day, very, very early on, Marcus Conant. Marcus was a gay dermatologist, had a large practice at UCSF, and he had heard of some of the patients with KS from his friend Alvin Friedman Keene, who is a dermatologist at NYU. Alvin had probably the largest collection of KS patients in the very, very early days. And Marcus, based on seeing one or two patients here and hearing about the ones in New York, thought, we will get organized. And right away, without any kind of authorization from the university, started a weekly discussion group. It never really had a name, but we generally called it the KS Study Group. And people just heard about it. People came. Actually, in the archives at the library here, there are some sign-in sheets. It's really fascinating to go look who came to these meetings. But the idea was people would just come and share what we knew. It was before the internet. You couldn't wait for journal articles to get published, so people just traded what they'd heard from all sites of the university, from the city, from the Department of Health, from community providers. And we often had people coming from the CDC because the epidemic was being studied so aggressively. Marcus and I decided to start a cohort of KS patients in derm. Because I was an oncologist at the General, we decided to refer them when they needed treatment to my oncology clinic. This is the first and maybe the only time when we saw a referral pattern from the private sector to the General. But it actually really was important in building the program at the General, because it allowed us to develop some clinical trials for the patients with Kaposi's. I shouldn't do this because it's dangerous, but I'll mention just a few people that were part of that group that came all the time. Jay Levy, who was my mentor in the lab when I thought I was going to be a scientist, who later discovered HIV himself. Art Amann, a pediatric immunologist, who in the same patient a young girl at Parnassus. A girl died of AIDS, and that hadn't been reported before, and she, it turned out, was the first blood transfusion-related transmission recognized in the world. So remarkably important. That was the case that made most of us really quite fearful, because it said this must be a virus. And that was at the end of 1982. And John Greenspan, who played an incredibly important role, described a manifestation that you could see just looking at a patient's tongue, and a very unique manifestation at a time when we didn't have a test for HIV. You could tell that somebody had AIDS just by a quick oral examination. So a remarkable situation. To prove that I had hair at one point, I included this slide. But really, this was Marcus Conant and me at the KS study group. You see it on the blackboard behind us. It was at a time when I don't think whiteboards were in common use then. But the other point of this is really the multidisciplinary nature of the response right from the very early days. And this was true when we began to grow the clinical services, especially at the General, that you know, there was so much disease in this illness that affected all parts of the body that we really needed the whole complex medical team, as well as all the other providers, obviously. Another a favorite slide, just because Donald Abrams on the left doesn't get remembered as much as he should. He was also an oncologist that came over to the General in '83. He, even starting when he was a resident at Kaiser here in San Francisco, began seeing patients with diffuse lymphadenopathy that didn't have AIDS, but they looked like they were, in quotes, I guess, at risk for AIDS, young gay men, and a condition that was a pre-AIDS condition that began to inform us that, you know, that this was maybe a bigger problem than just our AIDS patients might indicate, that there might be more people that were on their way to developing AIDS, and he called it AIDS-related complex, or ARC. And then on the right-hand side, Connie Wassi, when I went to the General in '81, Connie was there. I'd actually worked for her when she was kind of helping run the walk-in part of the ER at the General when I was still a fellow. But Connie wasn't trained in ID, but had a real interest and expertise in ID. And, you know, we divided up our talents a bit. I did most of the cancer. Donald did a lot of the work both in cancer and HIV in general. But Connie really focused on the opportunistic infections. She had a group that she organized called PCP for Lunch Bunch. That it was you know, kind of humorous, but they did some very serious work with understanding the opportunistic infections. And then, not here on the photo, but Gay Ling G, nurses have played an incredibly important role in the early AIDS epidemic, still do, but Gay Ling really helped create the multidisciplinary clinic that we called Ward 86. This is it's the 6th floor of building number 80 at the General. When we outgrew our space in the hospital where we started out, we were given some space on the 6th floor of building 80, Ward 86. Initially, just on the bottom part of the slide, on the south end of the floor. Later, the whole floor, and we opened in January of 1983. And this became a model clinic. People from really all over the world came to see. And you know, it's a really great, kind of gritty clinic, but the beauty of it really was the response, the really amazing, loving care team included more than just the docs. Another quick story, Ward 5B. This is a very blurry photo from a still from the movie. There's a great documentary that came out about a year ago called 5B that traces the history of this. It's really excellent. And here it was situation where the inpatient unit was really organized by the nurses, a very patient-centered, loving place with a lot of community participation as well. So just the history at the General was pretty amazing. I'll speed up a little bit here looking at my time, but another really important part of what happened was the interaction between the medical establishment, if you will, and the gay community. The early epidemic really affected gay men almost exclusively, and a number of organizations that either were already in existence, like the Shanti Project, providing bereavement counseling, shifted over. Others started. The AIDS Foundation, Marcus Conant and others helped get started. And remarkably, Project Open Hand, that was started as a voluntary meal service for 7 patients by Ruth Brinker, became a very large and important service, feeding thousands of people with AIDS in the early epidemic, at a time when people were literally starving from this disease. And then at the bottom, Martin Delaney, who started a group called Project Inform to share information. So the response was, a lot of us saw the medical response, but it was definitely part of the community which we turned to for help in caring for our patients. And then finally, in terms of the model, AIDS and Politics, Merv Silverman, who was the health director, was an amazing part of this response. Dianne Feinstein, who became mayor from the homophobic attack on Milk and Moscone, worked together. They had differences, especially around the bathhouse issue, but the response of the city and the health department was really essential. Now, there were some issues that I'll just mention. The press was then, as now, sometimes not always our best friend. This from the Daily News: AIDS could kill us all. Most of the press was good, but not always. And our response in the medical community was usually good, but not always either. This is Lorraine Day, who, if you see the movie 5B, is definitely featured in that. She was an overreactor, very afraid of catching AIDS, and we thought maybe that affected her professional response. Well, Molly wrote a great paper in a journal that no longer exists, the Western Journal of Medicine, but she pointed out that in terms of responsibility of physicians, it wasn't always the case that docs did a good job. From ancient epidemics, from 166 to the yellow fever epidemic in 1793, city dwellers were often abandoned by their physicians to decrease their risk. But in the yellow fever epidemic, I like this quote: physicians are justly considered as public property, and like military men, it pertains to their profession to be occasionally in the way of danger. Lots of reflections with today's situation. But in general, I think physicians increasingly have responded appropriately, and we saw that obviously with HIV, we saw it with Ebola, and we're seeing it now with coronavirus. So really quickly, science was hugely important. We over time learned the natural history of HIV and AIDS. We invested heavily in basic biology and immunology, which was essential, as it is today. And UCSF scientists were leaders from the start. We went from, as Peter says, horrendous situation where we didn't have any treatment. Then our treatments were really complicated. Today, almost all of our patients take 1 pill once a day with with 2 or 3 different medications, and it works. The mortality rate dropped as soon as we had effective therapies beginning in 1995, 1996. And a couple years later, in 1998, one of the local gay newspapers thought it was so remarkable that they didn't have any obituaries, that they had this cover, no obits. Before, in the bad days, as I think of it, there were many obituaries in every edition of the paper. So I've raced through HIV. It's, obviously, I think it was an important epidemic. I think our response was important and good. But now we're facing something new, and it's fortunate that we have new leadership taking over. I've loved seeing George Rutherford, who is a remarkable epidemiologist, Annie Lukemeyer, who's done a lot of great work with HIV, who's now really leading a lot of the treatment trials for CoV-2. So once again, I think San Francisco is going to play a really important role. A lot of similarities between HIV and SARS-CoV-2. I'll just mention a few. As I've said, zoonotic origins, primates for HIV, bats for SARS. Rapid global dissemination, even faster because of the important crossroads that China represents with this epidemic. There is transmission in both from asymptomatic infection, although it's tragic that we still don't know enough about the asymptomatic infection from the coronavirus. And deaths are terrible. I can't imagine a worse situation than HIV, but the deaths of people, not just old people, but people from inability to ventilate, are obviously something that we're trying to avoid. At first, in HIV and still in this epidemic, there was no treatment, no vaccine, and in both epidemics, the lack of testing for HIV because we just didn't have a test, and for coronavirus because it wasn't deployed, led us to really be trying to make things up without the data we needed. And we saw in some settings contact tracing with CoV-2. We never really saw that with HIV. There's some challenges, and the advantage in decreasing risk behaviors in the case of coronavirus is decreasing being in public. In both epidemics, I think political leadership was inadequate. We have a lot to say about Ronald Reagan, who refused to say the word AIDS until 1987. And then we have many things we could say about the current leadership. I think I won't, but we certainly, in a situation like these, need leadership. And really remarkably in both, Tony Fauci was a strong voice. Tony was one of the early leaders at the NIH in responding to the HIV epidemic. He took a courageous stand in responding to the patient advocacy and activism by actually bringing them inside the house, in a sense. The right thing to do, and he kind of always does the right thing, and we really treasure Tony a lot. There are differences, though, and I've tried to hint at some of these as I've gone through my talk. In HIV, there were only a small number of people, relatively speaking, at very high risk, and in SARS, we're all at the same risk, we think. HIV had a very long asymptomatic phase. SARS-CoV-2, we think, has a short asymptomatic transmission phase, but we don't know enough yet. The short period with SARS-CoV-2 allows us to approach containment, which wasn't possible with HIV. HIV was uniformly fatal. We don't know with SARS-CoV-2, probably in the range of 1% to 3%. Our risk as healthcare workers to HIV was, we worried about it, but it was in reality quite small. With the current coronavirus, we know that healthcare workers are, and those include obviously first responders, are probably at the highest risk, people that come into contact with more people shedding more virus. We didn't have a PCR in the early days. We didn't have the internet, so the sharing information was the problem. With the current coronavirus, when you look at the dates from China, the virus was identified very quickly after the initial cases. There was some delay, but not very long. But once the virus was identified, it was sequenced almost immediately, and that sequence was shared worldwide. In HIV, the care challenges really focused on outpatients. With the coronavirus, obviously, we're focused on acute and ICU settings. And HIV, although it had an economic impact, it was nothing compared to what we're seeing today. Again, a much, much smaller, slower epidemic. So finally, what lessons might we have learned by some of this experience? And I would again say, as I think I started, we don't know the lessons yet because we're still in the early days of the current epidemic. I think, though, that there are some that almost certainly will hold. The epidemic response, no matter which epidemic, benefits from planning and close connection between public health and political leaders. We were fortunate in San Francisco to have a very forward-thinking public health department. We had a great connection with the CDC, and we're concerned about maybe the lack of an effective response from the CDC with the current epidemic, but it requires that. It's essential to have data on community prevalence as soon as possible. As soon as we had the antibody test for HIV, Andrew Moss and others conducted random select sampling of the population in San Francisco. So quickly we knew where the virus was, how many cases were out there, and we clearly don't have that yet with this virus, but we need it desperately. A lot of lessons that we learned in HIV about communication. HIV was, again, not as broadly concerning to the public, but people were really afraid. And I think communication was essential. I think some of us learned it as we went along. People with expertise made themselves available, and that's still the case. I think a calm but honest tone, my experience is the best approach. I don't think you have to be a cheerleader. I think you can tell people based on science what we know, while at the same time recognizing and admitting that what we know will change. We want it to change because that's why we're doing research, and reassuring people that what we say may change tomorrow, but it's not because we were lying to you. It's because we've learned more, and that we promise to tell you what we've learned. This is probably, to me, the biggest lesson from the AIDS epidemic that I think still applies. In HIV, before we had effective treatment, people demanded access to anything that might work, really reminiscent of what we're hearing today. So in HIV, there were buyers clubs from treatments that had really no benefit, but people really were afraid and wanted it. And generally we said, okay, we don't really think they're useful, but we understand that and we'll reply. And we see obviously the same issues with hydroxychloroquine and other possible treatments in the current epidemic. The investment in basic science was crucial. We wouldn't have made any progress if we didn't do that, and I think the same is true. And I would hope that the research enterprise that UCSF represents can get back on track quickly, because it will be needed not just for the coronavirus, but for the next challenge that we face. We learned in HIV that it's safe to accelerate drug development and approval within some limits. And I think we're seeing it now. We're seeing the development of clinical trials that are really rapidly hitting the field. And then finally, we learned in HIV that healthcare needs a true team. It's definitely not just the docs. And in many cases, the docs weren't even the most important part of the team, certainly not when people were the most sick, where the nursing response led the way. So we've made progress. We have a lot more to do, but the AIDS quilt at the national capital a number of years ago, it's coming back to San Francisco. And I really, Peter, I want to thank you, and Raj, welcome to UCSF, and Marshall, good to hear from you, and thanks a lot, and stay safe. stay well, shelter in place, maintain your distance, use masks. So thanks a lot. Appreciate having the opportunity.
Thank you, Dr. Volberding. I'm going to turn it over to Dr. Stoller. We had a handful of questions during your wonderful talk.
Paul, could you comment on resident training during these epidemics, specifically managing the risk of infection and possibly diminished exposure to surgical training? And I remember in the early 80s, when Lorraine Day, like you talked about, sort of said, if you turn on the light switch, you know, would you go in if you thought that you'd get electrocuted? And he was at the general and very strong voice from the orthopedic department. So how do you view this about the residents being on the front lines and the recent death of a resident in New York yesterday?
Yeah, I know. You know, the situations are different between HIV and coronavirus, as I mentioned. But you know, we had people in the healthcare field dying of AIDS because of needle stick injuries, for example. There was a lot of concern, some of it understandable, some of it was a little exaggerated. But you know, again, healthcare workers have responded to challenging situations when their own health is at risk. That's part of our profession. I don't think it demands that we unnecessarily expose people to risk, and I think everything that we're doing now in terms of PPE and the rest for coronavirus is perfectly appropriate. There was a lot of concern in the AIDS epidemic. Molly did a number of surveys of this, that because we had such a high number of patients with AIDS at UCSF, that maybe students and residents wouldn't apply here for their training. That didn't seem to be the case ever. In fact, people came, I think, because they saw us as a model of response. So I think paying attention to the safety is obviously hugely important. I wouldn't underestimate that.
Another question, Paul, is why does the CDC seem less effective with the present pandemic compared to us going to the CDC before for the ultimate thoughts in the 80s?
Yeah, I know. It's a different world today, and I don't, you know, people obviously will be looking at this carefully for a long time to come. What happened? You know, in the AIDS epidemic, the CDC really led the charge. They were the beacon, and they were out here in California investigating the outbreaks. I don't know, but certainly the failure to rapidly develop and deploy tests was a failing. It has to be said. But why it happened, how it could have been prevented, I think we rely on investigations that are underway to tell us that.
You know, the stigmata of HIV was a major barrier to prevention and care seeking and treatment. Would you mind discussing the implications, what we've learned about this for the COVID-19 epidemic? You know, both, you know, ignorance, fear, myths, and discrimination. I mean, there's sort of some similarities, but maybe some differences there.
Yeah, I think there are probably more differences than similarities. HIV affected an already stigmatized subset of the population, gay men and injection drug users mostly, and it just added to that stigma. I was talking to a friend of mine, Jerry Friedland, who started out working in the Bronx, and you know, we were getting kudos in San Francisco for our response, and he said, you know, think of us, it's so much harder here. Their patient population was mostly non-English speaking injection drug users who nobody supported. At least here, the gay community had its political support, but no, there was stigma, and there still is. And with coronavirus, I don't think you see this same issue, because really everyone is at people are obviously very afraid of this. I would advise people not to cough in public, even if you don't have coronavirus, because people will probably run or throw things at you. But no, I think it's a different thing, Marshall. Yep.
Yeah. Have people at UCSF seen HIV patients with COVID? We don't really hear the association between the two.
Yeah, no, that's a really great question, and it's one that's being asked. We've actually asked some of our colleagues in China who were involved in the coronavirus outbreak there, where there are a number of HIV patients being treated. There doesn't seem, we don't have any real data yet, but there doesn't seem to be any particular adverse effect on risk or outcome. Mostly because most of the AIDS patients, HIV patients now are well treated with the current meds, including in China, with relatively high CD4 cells. So I don't think they're as immunocompromised. I think if an HIV infected person had a very low CD4 count, probably the outcome would be worse. But we haven't had enough experience to say yet.
You know, for Paul, for all of us who were in San Francisco in the 80s, it was always terrifying because we didn't know how HIV was being spread. Can someone come into your house? Could you wash your dishes? Are they going to use your toothbrush? All these things. How long did it take? And what was the story? How did you eventually figure out that it was sexually transmitted and not airborne?
Well, I think that the sexual transmission was pretty clear even from the earliest days, just by virtue of very sexually active gay men being seemingly the target population. But there were a lot of concerns. You know, is it safe to go into a restaurant? What if the restaurant worker is gay and cuts his finger and contaminates my food? And what about being on Muni? And so there were concerns. I think what addressed them was the testing. HIV testing became available in 1985. And then when we could start testing, you know, I was one of the first people. Jade Levy developed one of the early antibody tests for HIV. I was one of the first people tested, and when I found out that I was negative, it was not, you know, it was obviously reassuring to me, my family, but also it allowed us to say, look, if those of us that have been at the front lines of this, and we didn't use particular body substance precautions in those days either. So if we weren't infected, the risk of the public really, we could say, fully, honestly, must be essentially zero. You know, it's remarkable when I look back, when I moved here, I actually got an email just yesterday from a man who was my dentist in those early days. And I remember that in those days, dentists didn't use gloves when they worked inside your mouth. Couldn't imagine it today, but we just weren't as afraid of things as we later became. And so, again, we didn't wear gloves when we examined patients. We didn't wear masks, and yet we weren't infected. So I think that's what was really most reassuring.
Paul, I'll leave you with one last question. When we think about AIDS, both in San Francisco and around the world, you know, we think it's really changed society. I mean, people use condoms, their sexual behavior has changed. You go to the Golden Gate Park, you see the AIDS grove there as memorials. You see your beautiful quilt there. If we look 30 to 40 years down the line, what are people going to say about COVID? Is it still going to persist? How is it going to change our daily lives?
Well, you know, we are so much in the earliest days of this that I think anything we would guess today is, you know, it's certain to be different, even in a week maybe. But we desperately need a tremendously effective vaccine in a real hurry, because, you know, I don't know what's gonna happen otherwise. If this virus were to sit there and just be constantly kind of erupting. I think Tony Fauci has said that he thinks going forward, no one should shake hands anymore. We should just get rid of that as kind of part of our culture, that this idea of touching one another like that is probably always going to be at risk. I don't know. You know, we hope that this gets controlled quickly. We hope maybe that the virus changes somehow like the original SARS did, so it doesn't seem to be around. This doesn't look like it's going in that direction, so we really need a vaccine. But there's no question this is going to change history. We haven't seen anything like this since 1918. And let's hope we never see anything like it again.
Well, Paul, on behalf of the Department of Urology and the whole School of Medicine, we want to really thank you for your perspectives. as we go into this unknown world that we have, and hopefully we can learn things from the HIV. So again, thank you very much.
Oh, great. Thanks
you,
for inviting me. Yep.